Just the other day, a very young man came to me with his father. He was very anxious, very worried. He said, my father is behaving abnormally. My father said, there's nothing wrong with me, it's just that I don't know where these pink notes came into my purse. He was referring to the 2,000 rupee notes that had just been introduced after demonetization. He was working in a shop, was dealing with these notes, and had recent memory loss. He had absolutely no idea what those 2,000 notes were and how they entered into his purse. An elderly person having recent memory loss. We need to think of a condition called dementia. Ladies and gentlemen, in the next few minutes, I'll be talking about my journey, trying to find answers from within to solve the problem of dementia for families in the state of Goa and in our country. But what exactly is dementia? This is a picture, a slice of your brain, a wonderful organ having multiple neurons doing everything that you want to do. It works day in and day out. And this is what happens to the brain if somebody has a condition like Alzheimer's disease. You see on the right side is the half of the brain that has Alzheimer's disease. It's shrunk, it's atrophied. In fact, more than a century ago, Dr. Aloy Alzheimer first identified something called beta amyloid, an abnormal protein inside the brain that was leading to all these degenerative processes and leading to memory loss. We often take our memory for granted, but memory is extremely, extremely important for us to do our day-to-day activity. It's important for me to be able to give this talk to you. It's important for you to understand what I'm saying. It's important for you to remember what I'm telling you. But we often forget. We forget where we put our pens, right? We forget where we put our keys or mobiles. Sometimes we call up our cell from another phone just to find out where it is. That is not dementia. Because we do find it and life goes back to normal. A person with dementia may find his key and not know that it is the key to his new car. May find a mobile, look at it and not know how to use it. When memory problems are so extensive that they affect activities of daily living, that is the time we say it is not normal forgetfulness. It is probably a sign of a disease called dementia. Alzheimer's disease is one of the most common forms of dementia, and all the other forms as well are also seen in our clinics. Why should we be worried about it? Why are we talking about it here? Alzheimer's Disease International estimates that there are over 45 million people with dementia in the world. That is 450 lakh and above people with dementia in the whole world. In India alone, we have more than 4 million people with dementia. That is almost 3 times the entire population of Goa. And the numbers are increasing. We get 1 new case of dementia every 3 seconds. The numbers double every 2 decades. And you can see from this graph, the numbers are increasing at a much rapid pace in the low and middle income country. And why is that happening? It's because of a demographic transition that we are going through. With better health facilities, we are living longer. And so the elderly population is the fastest growing segment in the entire population. So conditions such as dementia, Parkinson's disease, stroke are also on the rise. And this is what we need to keep in mind. So my journey for people with dementia started when I joined MD at the Goa Medical College in Preventive and Social Medicine. And I was doing my thesis on dementia. And I must tell you that I was worried when I took off this topic because in my entire medical training, I had not seen a single case of Alzheimer's disease or dementia. And I was worried whether I'll get a sample size to complete my thesis. So on day 1, I went to the community, entered somebody's house, and I still remember the lady I met. Very nice lady sitting in the veranda. I went up to her, she looked at me, and she said, Baba, Kazar Zalo. Like all the grannies in Goa, I said, Baba, Kazar Zalo, are you married? I said, Na, mai. And I carried on the conversation with her. 2 minutes later, she stopped. She looked at me again into my eyes and said, Baba, tu kazar zalo? Asked me again. And she repeatedly asked me whether I was married again and again. And I knew dementia existed. I was on fire. I tried to find out more and more about this condition, went house to house. We did something called snowballing. You find out from the family, they don't know what it is, but do you know someone who has similar problems? They said, oh yeah, that auntie over there has a problem. So I would go there and find out what happened. And then I would ask the panchayat members and I would ask community health workers, do you know people like this? And they were all over the place. In fact, I finished my thesis in 6 months after joining. That was a problem, by the way, because when my people saw that, they said, you finished it too fast. Your thesis should go on for 3 years. And so they changed the thesis topic, which I did, by the way, but I was learning a lot. I learned that dementia exists. Around 2.9% of the people above the age of 60 had dementia. More than 12.5% people above the age of 80 had dementia in the state of Goa. But awareness about dementia was extremely poor. People wanted someone to come to the house. They're finding it very difficult to take a person with dementia to the health facilities. That is exactly why we didn't see cases during our whole MBBS teaching in the hospital. They don't go to the primary health center. They find it very difficult to go to a tertiary health system. And so they wanted someone coming to the house. The GPs would come to the house, but they would not really make a diagnosis. They wanted whatever help to be affordable. Because if somebody is coming to the house to give medical care, that could be very expensive. And we also realized that people with dementia needed help. At the same time, the caregivers, the people who were looking after people with dementia, also needed a lot of help. That is the time I met other like-minded people. Dr. Shikavas was a neurologist who had just come. He was the only neurologist in Goa at that time. Dr. Vikram Patel, Dr. Rajesh Dume, and caregivers. I remember Jean D'Souza. She was looking after her mother with Alzheimer's disease for the last 8 years, and she became part of a society. We formed the Dementia Society of Goa to try to find solutions. What I realized is that I was presenting the data in conferences. I was invited to Washington when I was a student to present this at the World Alzheimer's Congress. My papers were getting published, but I was just converting people into a statistic. We had to do something for the community. We had to look for answers within. We often look elsewhere for the answers. We had to look for answers within. We look around and we saw that people with dementia still looked after by their families. Can we help the family member look after the person with dementia differently by training the family member? Now, it's difficult for us to send psychiatrists and neurologists to somebody's house to do that. We have so many people. We have such a huge population. Can we train people from the community to go around to the family, visit families, and try to help them deal with the problem of dementia? We were lucky at that time. It was just an idea. But the Ministry of Social Justice and Empowerment and the World Health Organization came to our rescue, and they funded a small project to try to develop this kind of an intervention. So we can train community workers to be able to intervene under supervision and try to make a difference in the families of people with dementia. And the question in your mind, and probably in our mind at that time, was if we're going to train lay health workers or community workers, are we dropping the quality? Will it be impactful? Will it ever make a difference? Can it be counterproductive? So that is why we try to evaluate this intervention using the same robust method that we use for introducing a new drug. We used what is called a randomized control trial. What it simply means is that some families got the intervention, while the others didn't get the intervention. They got it after 6 months. And then we evaluated the ones who got the intervention with the ones who didn't get the intervention, and we tried to see the difference. The disease was complex, and so the intervention also was a little complex. I'll try to simplify it and just tell you what I call the ABCD of the intervention. And I'll start with D. D stands for the diagnosis of dementia. We realized in our work that more than 90% of the families had no clue what was happening to their loved one who was having these memory problems and behavioral problems. They didn't know what was happening and they didn't know what to do about it. Despite the fact that more than 55% had actually seen a doctor in the last 3 months, but yet there was no diagnosis. They were given some vitamin tablets and sent back. we had to start with the diagnosis. The diagnosis of dementia is the first step to care. The second bit is the C. C stands for the caregiver. We realize that if we have to make any impact on the quality of life of the person with dementia, we have to address the issue of the caregiver. 80% of the caregivers were women. More than 50% were old themselves. They had caregiver burnout. They didn't know what they were looking after. They didn't know who they were looking after. They didn't know why it was happening to them. Some of them suicidal. Some of them having marital conflicts. They were telling us, it's very difficult for me to look after the children, husband-related issues, do the shopping, cleaning, and also looked after my grandmother or my mother-in-law who's behaving this way. And then sister-in-law walks in and says, she's your cross. You have to bear it. We had to address the issues of the caregiver. C is also comorbidity. We realized that a lot of people with dementia also had diabetes and also had hypertension. And because of having these memory problems, and this was like overpowering everything and overshadowing everything, they were not treating the diabetes and not treating the hypertension. We had to intervene there because we know that these are risk factors and can worsen the condition. C is also communication. I remember Christine Bryden, she's a person with dementia, was working for the health services in Australia, and she visited Goa many years ago. She was talking about what does it feel like to be a person with this diagnosis. And she said, we are not cognitively impaired. Memory is not a problem. We are communication impaired. We want to say it, but we can't say it, or you can't understand it. And we had to address that issue. We had to learn or teach people how to communicate with people with dementia. That brings us to B. B stands for the behavioral problems that are associated with people with dementia. Very often, it's not the memory that people are worried about. It's because of the memory problem, there are behavioral issues. Grandpa goes to brush his teeth, and instead of using toothpaste, will use shaving cream. Wants to go to the toilet and goes to the kitchen and uses the dustbin. We have to address the issues of behavioral problems in people with dementia. They could be wandering, they could be sleeping in the daytime and awake at night, but there are simple ways that we can actually deal with the problem. We learned these simple ways by talking to others who are looking after people with dementia for 8 years and learning along the line. We thought of giving this information to the others. And that's what our community health workers did. Under supervision, they were supervised by a psychiatrist, they were supervised by a counselor, but the community people from the lay community were making this difference. And also brings us to A. A is for activities of daily living. As I said, memory problems affect us to such an extent that we can't do our activities of daily living. Day-to-day activities becoming difficult for us to brush our teeth, difficult for us to eat, difficult for us to decide when we want to go to have a bath, difficult for us to complete a sentence. So we would assist people with dementia in the activities of living. 2 years later, we analyzed the data, and we found that a simple intervention like this had made a dramatic impact on the stress levels of the caregiver burnout. It had reduced the stress levels in the caregivers. It had statistically significantly reduced the behavioral problems in people with dementia. Also reduced the perceived burden in the caregivers. What we also noticed, and this is not something we were looking out for initially, 18 people died in that 2-year period while we were doing this study, but the number of people who died in the intervention arm, the ones who got the help, were half that as compared to the control arm, which meant very clearly we were making an impact on the quality of life of people with dementia. In fact, this study won the international prize from ADI and Alzheimer's Medrik Fundação for being the best evidence-based psychosocial intervention for people with dementia. Thank you. I belong to a group called the 1066 Dementia Research Group. It has a very odd name started by Professor Martin Prince and really stands for the fact that only 10% of funding for research go to an area where 66% of people with dementia live, countries like ours, India and China. And we need to readdress this. And we believe very strongly that good quality research, the type that we did, would help to generate awareness. And that was what was happening. The media was now reporting. Policymakers could get figures to decide what they should do and where they should go. It helps encouraging service development. Today, we provide the home care service for people with dementia free of cost to anybody in Goa. If they give us a call through the NGOs that I support, we provide this service free of cost to anybody in Goa. We also train home care nurses in the module for dementia, and families can then employ home care nurses to help the family members of people with dementia. But we ultimately want to shape policy. In fact, what we did, we wrote something called the Dementia India Report and gave it to the government with policy prescriptions on what needs to be done to help families of people with dementia. What we see is that medical care is getting over-specialized. You want to deal with diabetes and you want to search an endocrinologist for that. And you want to deal with a simple problem, you want to see a specialist for that. This is also something that the ADI had observed in its report last year. And it said that dementia care is also getting over-specialized, which is not really necessary. We can train the primary health center staff to deal with the problem. We have to integrate the type of service that we have developed into primary health care. We have done that with tuberculosis, we've done that with malaria, we've done that with maternal and child health. We can do it with elder care. And that is the way forward. I also took a step back in order to go forward and came up with a program called the Minded program. I mentioned this to you earlier, the abnormal protein called beta amyloid that is collecting inside the brain that is causing all the problem. Over the years, we still feel it is the beta amyloid that's causing the problem, but we now know a lot about what is leading to the formation of beta amyloid. And we now know that dementia and Alzheimer's disease is also a lifestyle-related disease. So many of you will say it's a lifestyle-related disease that occurs at the age of 60, so tell grandpa to go for a walk and everything will be fine. No. Lifestyle-related diseases, the problem like atherosclerosis that ultimately block your vessel, the changes take place much earlier on. And that's the philosophy behind our Minded program. We're trying to encourage students to accept a brain-healthy lifestyle. And it was very successful. I started off by taking 8th, 9th standard students. This year I also went to 3rd and 4th standard students, and they were extremely enthusiastic. I always love teaching, and I love teaching children as well. This also fits in very well with my new work, which is on prevention of depression in late life. I'm doing work with Professor Charles Reynolds, and the project is called DIL. Again, we're doing a randomized controlled trial to see this. And we also see there is a link between depression and dementia. And the results will be out soon. What I would like to say is that dementia is a public health problem. But life does not end with the diagnosis of dementia. We can make a big difference in the lives of the families of people with dementia and for the person with dementia himself. And if we have to build a community that is friendly for people with dementia, a dementia-friendly community, then the community has to play a big role. Yes, there is a role for the neurologist, psychologist, and others, but the community has to play a big role. And my dear friends, the community is us. We can make a difference. Let us today take that pledge and say that we care for those who care for us. We remember those who cannot remember. Let us care for those who cared for us, our mom and dad, and let us make a difference. Thank you.